A very good evening and warm greetings to one and all the wonderful dignitaries who have joined in today's Wednesday Wisdom. From the team MahaIP and MahaIP Women Committee, I welcome you all. I, Dr. Amrita Pavaskar, convener MahaIP Women's Committee, and my colleague, Dr. Swapnali Madam, who is an executive board member of the MahaIP Women's Committee, are the coordinators for today's Wednesday Wisdom. Since we are celebrating anemia awareness presently and ongoing with the present theme, today's CME would highlight about various aspects, clinical clues, diagnosis, and management related to anemia. It gives me immense pleasure to welcome our MahaIP President, Dr. Ram Gopal Chejara, sir. Also, we have Dr. Amol Pawar, sir, and Manjusha Shekhar, madam, who is a MahaIP Women's Committee chairperson. Today's MMC observer is Dr. Sanjay Gosavi, sir, who is a senior consultant pediatrician from Nasik. I request Dr. Ram Gopal, sir, to say a few words. Over to you, sir. Sir, kindly unmute, please.
Good evening, everyone, and a warm welcome. Nice to see attendance of almost 200 within 5 minutes. So I welcome our experts for today, Dr. Rashmi Dalvi, madam. She is a hemato-oncologist from Bombay Hospital, and Dr. Shailesh Kanvide, sir. He is from Pune. He is also a hemato-oncologist. And all the presenters for this episode, I congratulate and appreciate the work done by the Women Committee, specifically Manjusha Madam, Chairman of the Women's Committee, Co-Chairperson Dr. Grevita Raikar, and Convener Dr. Amrita Bhaviskar, and all the EB members of Women's Committee. They are so enthusiastic that they have started working for the next episode also. So really appreciate and congratulate them. Okay, so over to Amrita. You can start the program.
I request Dr. Amol Pawar, sir, Secretary MahaIP, to say a few words.
Thank you. Thank you, Dr. Amrita. Welcome both the speaker, Dr. Rashmi Dalvi ma'am and Dr. Shailesh Kanvinde sir from Pune. Both are senior hemato-oncologist. Then Dr. Sanjay Gosavi sir, today's MMC observer. He is senior pediatrician from Nasik. And all the speakers from different zones of Maharashtra, and Women Committee Chairperson Manju ma'am, Grevita ma'am, President Dr. Ram Gopal sir, all the office bearers of various branches of Maharashtra, and all the zonal committee members and all delegates also. This is a very nice initiative. This year we have come up with MahaIP's Wednesday Wisdom, and in which the speakers less than 45 years of age are groomed to become speakers at state level and further national level also. So without delay, we will proceed for today's episode. Over to Amrita ma'am.
Thank you, sir. I request Dr. Manjusha madam to say a few words, and I also request madam to give her final words at the end of the session.
Okay. Thanks, Dr. Amrita. Good evening, respected dignitaries. Today's experts, Dr. Rashmi Dalvi ma'am and Dr. Shailesh Kanvinde, MMC observer Dr. Sanjay Gosavi sir, our MahaIP President Dr. Ram Gopal sir, Honorary Secretary General Dr. Amol Pawar sir, CIP and MahaIP OBs, ZBs, Dr. Renu ma'am, Women Committee zonal members, all talented speakers and all enthusiastic attendees. On behalf of MahaIP and MahaIP Women Committee, I, Dr. Manjusha Shekhar, as the Chairperson Women Committee, welcome you all and wish everyone a very happy learning. We all know today's topic having a prime concern regarding women and child health. So let's learn overview of anemia. Thank you. Over to you, Amruta.
Thank you, madam. I request Supnali madam to introduce our experts today, and then we can start with the program.
Yeah, thank you so much. Very good evening and welcome to all for Wednesday Wisdom session. I, Dr. Swapnali Doka, Zonal EB member of Women's Committee, take an opportunity to welcome and introduce today's expert for the session, Dr. Rashmi Dalvi ma'am and Dr. Shailesh Kanvinde sir. Both are stalwarts in their fields. Dr. Rashmi Dalvi ma'am, she has done her MD and DCH. She has been chairperson for International Society of Pediatric Oncology for Advocacy Committee. She is senior consultant pediatric hematologist oncologist, professor and HOD of Bombay Hospital and SRCC Children Hospital, and visiting consultant PHO and BMT LTMG Hospital. She was continental president of International Society of Pediatric Oncology Asia in 2018 2002 till 2021, and she has been chairperson and PHO chapter head IAP 2009 to 2012 and national coordinator NTP PPO oncology for pediatrician. So, and she has bagged many awards in her career. So welcome you, ma'am, for this session as an expert. Our next expert is Dr. Shailesh Kanvinde sir from Pune. He has done MD Pediatrics from BJMC and he is consultant pediatric hemato-oncologist. He's consultant at Dinanath Mangeshkar Hospital, Pune, and he has been trained at Tata Memorial Hospital, Mumbai in pediatric hematology, oncology, and bone marrow transplant. We are honored to have you over here, sir. Thank you so much for gracing the occasion. Now, I'll introduce speaker. Today's our first speaker for this session, Dr. Vaibhavi Barot ma'am. She's practicing pediatrician at Ankur Multispeciality Hospital, Virar, for last 20 years, secretary of Palghar Academy of Pediatrics, and she has published papers in indexed journal too. She will be speaking on anemia in newborn. Over to you, ma'am.
Thank you, madam. I thank MahaIP and MahaIP Women's Committee for giving me an opportunity to speak today in the Wednesday Wisdom. And I also thank Dr. Rashmi Dalvi madam for helping out me during the PPTs. Today's theme being Anemia Awareness Day. Today I'm going to speak on anemia in newborn. So anemia is the most common hematologic abnormality in newborn. Specific incidence of anemia depends on the cause of anemia. In neonatal period, anemia can be physiologic or pathologic. So how do we define anemia?
Excuse me, ma'am. Have you started your PPT?
Yes, sir.
Is it visible?
Screen sharing.
No, ma'am. Your PPT is not visible.
No, you are not shared. Please
share the PPT. Madam.
Okay, sir.
Good evening, Dr. Shailesh Kanvinde sir.
Is it visible now, sir?
Yes. Sharing started. Make it a full screen.
Okay, sir. Yeah.
Okay. Please go ahead, ma'am.
Yeah. Okay, so should I start from beginning? Okay, introduction. Anemia is the most common hematologic abnormality in newborn. Specific incidence of anemia depends on the cause of anemia. And in neonatal period, anemia can be physiologic or pathologic. Now, how do we define anemia? So, anemia in a neonate who is more than 34 weeks gestation is defined as cord or venous blood hemoglobin less than 13 gram per deciliter or a capillary hemoglobin of less than 14.5 gram per deciliter or a venous hematocrit of less than 45%. It is also defined as hemoglobin or hematocrit less than 2 standard deviation below the mean for a particular gestational age. Regardless of any gestational age, any neonate with hemoglobin of less than 14 gram per deciliter at birth is considered anemic. Now we'll see the RBC physiology at birth. So during in utero period, the oxygen saturation in blood in a neonate is less. Because of the hypoxia, there is stimulation of the erythropoietin, which in turn increases the hemoglobin, the increased nucleated RBCs and increase in the reticulocytes. Now after birth, when the newborn takes the breath, there is increase in oxygen saturation. In turn, there is decrease in erythropoietin. The hemoglobin decreases, the nucleated RBC decreases, and the reticulocyte is then less than 1%. Now, what happens in physiological anemia of infancy? So, when the child takes its first breath, the oxygen saturation, which was initially in utero 50, increases to 95% and more. Then there is also switching from fetal to adult hemoglobin. Adult hemoglobin has low oxygen affinity, so more oxygen delivery. Increased delivery of oxygen to the tissues. This leads to no hypoxia in the tissues. In turn, there is decreased erythropoietin production, and which causes suppression of erythropoiesis. Now, hemoglobin decreases until the oxygen need increase until the tissue needs oxygen. This reaches by 8 to 12 weeks. Now there is hypoxia, which is detected by renal and the hepatic sensors. Then there is erythropoietic production. Erythropoiesis increases the hemoglobin production. This physiological anemia of infancy is a benign thing and it does not require any treatment. Now, what is anemia of prematurity? It usually occurs in preterm babies, and this is an exaggerated response of the physiological anemia of infancy. The hemoglobin nadir is reached earlier and is lower than the term infants. Average nadir is 7 to 9 grams per deciliter and is reached at 4 to 8 weeks of age. Now, this happens due to the combination of decreased RBC mass at birth, increased iatrogenic losses due to phlebotomy, shorter RBC lifespan, inadequate erythropoietin production, low iron stores, rapid rate of growth, and vitamin E deficiency. What are the symptoms of anemia in a newborn? So they could be poor feeding, rapid heartbeat and breathing, there is irregular breathing, weight loss, failure to thrive, then the child looks pale, and the weakness means the child is lethargic. Now, what is the pathophysiology? So anemia in the newborn results from 3H. Very simple to remember: hemorrhagic, hemolytic, and hypoplastic. So hemorrhagic anemia can be because of antepartum, intrapartum, or neonatal period. So in antepartum period, we have loss of placental integrity, like in abruptio placenta, placenta previa, traumatic amniocentesis, or it could be because of anomalies of the umbilical cord or placental vessels, like in velamentous insertion of the cord, communicating vessels, cord hematoma, entanglement of the cord, or vasa previa. Then there is twin-to-twin transfusion syndrome. It occurs only in monozygotic multiple births, and there is 13 to 33% of twin pregnancies who have twin-to-twin transfusion syndrome. The difference in hemoglobin in them is usually more than 5 gram per deciliter. There is congestive heart disease common in anemic twin, and the hyperviscosity is common in the other plethoric twin. Now, in intrapartum period, we have the feto-maternal hemorrhage. This is due to increased risk with breech delivery. Then there are placental malformations. This traumatic rupture of the cord, or it could be because of failure of placental transfusion due to cord occlusion, like in nuchal or prolapsed cord. There could be obstetric trauma causing occult, visceral, or intracranial hemorrhage. Now, in neonatal period, it could be because of the enclosed hemorrhage, suggestive of obstetric trauma or severe perinatal hypoxia. There could be hemorrhagic caput succedaneum, cephalhematoma, intracranial hemorrhage, or visceral hemorrhage. Then there is defects in hemostasis, like in congenital coagulation factor deficiency, consumption coagulopathy, DIC, sepsis, vitamin K dependent factor deficiency. There could be thrombocytopenia, which could be immune or congenital. And the main cause, iatrogenic blood loss due to blood loss. Now, hemolytic anemia, the causes are immune hemolysis, like in Rh, ABO, minor blood group incompatibility, or autoimmune hemolysis. Then it could be a non-immune, like sepsis, torch infections, congenital erythrocytic defect, G6PD, thalassemia, membrane defects, hereditary spherocytosis, elliptocytosis. Then systemic diseases like galactosemia, osteopetrosis, or nutritional deficiency like the vitamin E. Hypoplastic anemia occurs maybe in congenital, acquired, or drug-induced. Congenital, we have the Diamond-Blackfan syndrome, congenital leukemia, sideroblastic anemia, and acquired infections like the rubella and parvovirus are the most common. Now, how do we approach a newborn with anemia? So, we always take the history first. So we ask for the family history like anemia, jaundice, gallstones, and splenectomy in the family. Then we ask for the obstetric history like severe abdominal pain, which could be because of abruptio or intrapartum blood loss could be there. Then investigation wise, we do the hemoglobin, RBC indices, reticulocyte, blood smear, direct Coombs test, blood type, and RH in isoimmune hemolysis. Now, once we get the hemoglobin, then we do the reticulocyte count. If the reticulocyte count is normal, suggestive of congenital hypoplastic anemias, congenital infections, or congenital leukemia. If the reticulocyte is normal or high, then we do the Coombs test. If the Coombs test is positive, it indicates immune hemolytic anemia like the ABO, RH, minor blood group, example KL. And if the Coombs test is negative, then we do a MCV, that is the mean corpuscular volume. If it is low, it suggests chronic intrauterine blood loss or alpha thalassemia syndromes. If the NCV is normal or high, then we do a peripheral blood smear. If the peripheral blood smear is abnormal, then we think of hereditary spherocytosis, elliptocytosis, stomatocytosis, poikilocytosis, pyruvate kinase deficiency, G6PD deficiency, and DIC. If the peripheral blood smear is normal, then think about infections or some rare miscellaneous causes, example, hexokinase deficiency. Or it could be just blood loss, which could be because of iatrogenic, that is sampling, fetomaternal or fetoplacental, then twin-to-twin transfusion, internal hemorrhage, placental hemorrhage, and umbilical cord hemorrhage. The other tests which can be done are the Clearhore-Betke test on maternal blood to look for fetomaternal hemorrhage. Then we can do a chest X-ray to look for pulmonary hemorrhage. Bone aspirations for congenital hypoplastic or aplastic anemia. Torch levels, we do the IgM levels, and we do urine for CMV.
Vaibhavi,
DIC.
madam,
Vaibhavi?
Yes, madam.
Your time is up.
Okay. Should I run fast?
Your time is up.
Any 1 or 2 minutes you can
2
finish it
minutes.
fast.
2 minutes. 1 minute you can take, Vaibhavi, madam.
Okay. So then management part I'll finish. So any infant with acute blood loss more than 10% with symptoms of decreased oxygen delivery occurs, or if significant hemorrhage of more than 20% total volume, severe anemia of antenatal onset like RH immunization with cardiac failure, or there could be antepartum hemorrhage in shock. These are some transfusion guidelines for premature infants. The practical points for blood transfusion are in neonates, we usually use the same donor because we require multiple aliquots. Blood should be fresh, 3 to 5 days old for more 2-3 dpg. Then in cross match, we usually send both the baby and the mother's blood sample. Blood is usually given in the dose of 15 to 20 ml per kg, and 9 ml per kg body weight increases the hemoglobin level by 3 gram per deciliter. Blood usually used is leukocyte depleted cells, preferably to reduce the CMV transfusion. And in neonates, we usually use the irradiated blood cells to reduce the graft versus host disease. Feeding should be continued for a stable baby, and strict asepsis should be maintained during transfusion. No routine use of furosemide during transfusion. Now, prevention of anemia can be done in delivery room practices like the delayed cord clamping, milking, or stripping of the umbilical cord. Then reduce the blood samplings, use micro sampling, adopt transfusion guidelines, and erythropoietin to early administration in selected circumstances, and iron supplementation 2 to 4 milligram per kg per day as prophylaxis in preterm from 4 to 6 weeks of gestation. Thank you, madam.
Thank you so much for your flawless presentation. I request today's expert, Dr. Rashmi Dalvi ma'am, please comment on this.
Right. So first of all, I'd like to thank you for inviting me to this forum, and congratulations to Dr. Ram Gopal, Maha-IAP, Women's IAP Forum for this wonderful initiative. I mean, it's really something great. And from the first presentation, I can see that it's something really encouraging and great to have. So, and also congratulations on having this kind of webinar to celebrate, I believe, I suppose the National Anemia Day week.
Yes, ma'am.
So on. Now, anemia overall is the commonest hematological problem that we encounter, whether it's newborn or older child. And anemia is something which cuts across all specialties of medicine and pediatrics, of course. So coming to the newborn, and Dr. Vaibhavi, thank you for a very excellent, very lucid, very clear and very confident presentation. And what I want to say is that, we more often see probably polycythemia as a problem than anemia in the newborn. But what is important to remember is that because the hemoglobin levels that we are talking about are higher, clinically, sometimes it may, you may miss seeing a child, until the hemoglobin goes down to 6 or 7, you may not see that significant a pallor. So you have to have a high index of suspicion for a dropping hemoglobin. And she has very clearly enlisted all the various causes that you encounter. So apart from all, one thing I want to say is that some of these causes are preventable. So maybe she was going to talk about it later, and we had to cut short the talk. But so you have to be one thing is anticipatory for some of the forms of anemia. For example, hemolytic disease of the newborn, when you have had a previous history, or if you have there's a family history of, G6PD deficiency with a relevant sex of the child, or any other enzyme deficiency, hereditary sclerosis. So those, if you know of these situations, you have to be anticipatory about it. Also, some of these causes which are preventable, I won't go into all the intrapartum and all those, but just remember that something like early vitamin K deficiency, which she mentioned. So that can be present first as anemia and convulsions. And here you have to remember that early HDN, classic HDN, of course, you cannot prevent as such other than giving vitamin K at birth. But early HDN can definitely be prevented. So mother who's on warfarin or who's on anti-tubercle therapy, anticonvulsants, hepatic enzyme inducers, these mothers, you should be wary about these bleeds. And again, in a newborn, most things, you have to act quickly, because sometimes, they may not be able to tolerate that severely low hemoglobins. So, clinically and otherwise. So you have to basically act quickly in your investigations. Regarding investigations, I'm glad she mentioned retic count, because that is something very often which, you just do a CBC and the retic doesn't get done. So retic is important. It's a window to the bone marrow. Although in a newborn, we know that the bone marrow actually gets switched off soon after birth because of all the reasons that Dr. Vaibhavi has mentioned. Then peripheral smear is something also as good as, what a history is to a clinical diagnosis, a peripheral smear is to a hematological diagnosis, and same holds true for the newborn as well. So getting the right person to take a good look at the peripheral smear is important. And I think that flow chart which she has outlined is also a very good one, and a very good indicator to how you should go about thinking about these areas. So yes, that's it.
Thank you so much, ma'am, for throwing light for the anticipatory measures for the newborn. So we will be moving forward to next speaker. Before that, I would like to tell, time given to each speaker is 10 minutes. And if audience have any questions, they can put in chat box. So that will be discussed after the session. So our next speaker is Dr. Amruta Umesh Hirve ma'am from Nasik. She is consultant pediatrician at Sahyadri Hospital, Nasik, and working at Chandoba Child Clinic at Nasik. So ma'am will be speaking about nutritional anemia. Over to you, ma'am.
Amrita madam, please share your screen.
Yes, ma'am. Good evening, everyone.
You can make it
First,
the presentation.
yeah.
Please. Yeah, good. Now we can start.
Good evening, everyone. Thank you for giving me an opportunity to represent on this platform. And thank you very much, Dalvi ma'am, for your guidance, valuable guidance for making this presentation. So my topic today is nutritional anemia. As per the comprehensive National Nutrition Survey, it has been known that more than 50% of nutritional anemia, childhood anemia, are due to underlying nutritional deficiency. So nutritional anemia is, we say nutritional anemia develop when the hemopoietic nutrients required from the hemoglobin synthesis and or the maintenance of hemoglobin are insufficient. Nutrients required for erythropoiesis are protein, few essential amino acid, trace element, very important, is iron, copper and zinc, folic acid, vitamin B12, vitamin B6, vitamin B2 and vitamin C. As per the WHO, the cutoff for each age group, cutoff hemoglobin level for each age group is mentioned in this chart. But as per the Comprehensive National Nutritional Survey in 2019, the cutoff derived for Indian populations are 1 or 2 grams per DL lower than WHO suggested cutoff for all ages. Prevalence of nutritional anemia is increased from 59 to 61% in last 5 years. It is a red flag for Indian government as well as as a pediatrician. Highest spike reported in 6 months to 59 months, which is around 67%. Incidence of nutritional anemia is more in female, especially the adolescent female, which is around 87%. According to etiology, the nutritional anemia contributes to 67% to all anemia, 68% of all anemia. Iron deficiency anemia is more common in under 5 years. Folate and vitamin B12 deficiency is higher among the school-going and adolescent age group. 10 to 18% of children and adolescents have combined iron and folate or vitamin B12 deficiency anemia. The causes of iron deficiency anemia are diminished store, which is preterm and SGA baby, early cord clamping. Second common cause is decreased iron intake, that is due to malnutrition, infection, and the babies who are not on breast milk, who are fed on the cow's milk, which is deficient in iron store. Decreased iron absorption, which is seen in malabsorption or due to increased intake of inhibitors. Increased demand of iron when there is a rapid catch-up growth in the preterm baby, and there is an increased demand during the infancy or puberty.
There are few inborn error of metabolism, that is hemosiderosis, sideroblastic anemia, and congenital transferrin deficiency. This chart is clearly showing that the stages of iron depletion, where we can see what we can see or diagnose as iron deficiency anemia is only the iceberg of the disease. The actual burden and subclinical cases are much more than what we can see in our day-to-day practice or be diagnosed. Also, in general, anemia never present as a disease. It's mostly associated as a comorbidity with other infections and illnesses. And as per this chart, as we can all see, till there is a clinical signs of iron deficiency anemia there is all factors like hemoglobin, MCV are normal. Only the importance of serum ferritin level, which is very important for the early screening of iron deficiency anemia. Clinical features of iron deficiency anemia. Iron deficiency anemia is more of a clinical diagnosis. Most of the time, it is a presumptive diagnosis in many of the cases of malnutrition and nutritional deficiency children. The clinical features are pallor, failure to thrive, easy fatigability, increased frequency of infection, and also the duration of illnesses is more than usual. Atrophied tongue papillae, thin brittleness, chylonychia, pica, congenital cognitive functional impairment, poor school performances, decreased productivity, and effectively economical loss of the country. In severe cases, we can find cardiomegaly, CCFs, and septicemia. Diagnosis of the iron deficiency anemia. The diagnosis of iron deficiency anemia is more of a clinical finding and less of the diagnostic test. History and clinical examinations clinical signs and symptoms are important to diagnose the nutritional anemia, especially the iron deficiency anemia. As I told in last slide, presumptive diagnosis is made most of the cases who are malnourished children. And iron deficiency anemia is most of the time present as a comorbidity with long-term repeated infections and the septicemia or the repeated infection present in children. The lab diagnosis for iron deficiency anemia shows the low HB for age, peripheral smear suggestive of microcytic hypochromic anisocoilocytosis. The triad of low MCV, low MCH, and low MCHC for age. Retic count is very important to monitor the response of therapy in iron deficiency anemia. Red cell distribution test, which measures the difference in the volume and the size of the red blood cells, that is RWD, is also done. Serum ferritin level is very reliable marker for the body iron store. Less than 20 microgram per liter is the cutoff for less than 5-year-old children, and less than 50. Yes, ma'am.
2 more minutes. 2 more minutes.
Yeah. 2 microgram per liter for above 5 years. Transferrin saturation may be used when there is serum ferritin level are equivocal. Now we go for the treatment of iron deficiency anemia. We have to treat for the underlying cause like deworming, treat the cause of persistent blood loss like colic, chronic dysentery. And nutrition and changes, dietary habits is the main intervention we need to do to correct the nutritional anemia. Mostly nutritional anemia, oral iron therapy is the preferred choice, for which ferrous salts are used, which have a good availability and cost effective. The dose for oral iron therapy is 2 to 3 milligram per kg per day elemental iron with folic acid. Duration is 2 to 3 months after the hemoglobin level normalizes. Prefer single daily dose for oral iron therapy. For mild severe anemia, we have to take follow-up after 1 week of starting oral iron therapy and after 2 weeks with mild to moderate anemia. Co-administration of cobalamin, folic acid and vitamin C is also recommended. Parenteral iron therapy is indicated when there is non-tolerance of oral therapy, when there is a requirement of rapid replenishment, ongoing blood loss is there, iron malabsorption there, or chronic kidney diseases. Parenteral iron therapy is indicated. Then we prefer an intravenous route.
Dr.
Iron sucrose and ferric dairy.
Dr. Amrita, time is up, please.
Just last 2-3 slides.
Yeah.
Dose for iron parenteral iron therapy is 1 to 4 microgram. Blood transfusion is required only in severe anemia, sepsis, and CCF or hemoglobin level less than 4 grams per dl. When there is no response or there is patient is showing less than 1 gram per dl rise in hemoglobin, we called it as non-responsive. Prevention of iron deficiency anemia. We have to, along with the breastfeeding, preterm iron supplement, food fortification, along with that routine screening for anemia, IAP awareness program and guidelines, government program like Anemia Mukta Bharat, National Iron Pulsing, National Nutritional Anemia Control Program. Second common anemia of nutritional anemia is megaloblastic anemia, which is caused due to vitamin B12 and folic acid deficiency. The main important point in this megaloblastic anemia is whenever we suspect megaloblastic anemia, we have to specifically look for vitamin B12 and folate level. If we are suspecting mixed deficiency, we have to start the therapy with vitamin B12 alone is to be started initial 10 to 14 days, followed by additional folic acid to avoid worsening and precipitation of neurological symptoms. In case of PM and severe anemia, lower doses of vitamin B12 has to be used to avoid life-threatening hypokalemia. And duration of therapy in vitamin B12 deficient megaloblastic anemia is 3 months for hematological manifestation and 6 months for the neurological manifestation. And just to sum up, nutritional anemias are preventable. Nutritional anemia can be controllable and treatable. Interventions are simple and very affordable, needs public awareness, government policies, and IAP guidance programs. Thank you.
Yes, thank you so much, Dr. Amrita. Very well said at the end. I would request Rashmi ma'am to give her opinion on this.
Thank you. I think Dr. Amrita has done a wonderful job and very precise and clear. And I mean, I also, it's a nice revision and I also learn a lot from these, really good. So I just want to say that, nutritional anemia again is amongst all anemias, it is the commonest problem that we see, one of the commonest problems that we see in pediatric hematology oncology. And also in general pediatric practice, also among the hematological problems you see, this is the commonest situation that you come across. It's very important to be able to prevent or treat nutritional anemia early, because commonest time for iron deficiency anemia is in the first 5 years. And the first 2 years are very critical for your brain development. And if you have chronic, iron deficiency during this period, it can lead to cognitive defects in later life. Also, what Dr. Amrita has mentioned is that when you talk about iron deficiency anemia, it is the tip of the iceberg, What you have before that is an iron deficient state. And so even if you have a patient with hemoglobin of 10 and 11, but MCV is low and it's not actually a Thal minor or something, you must treat these patients because, iron, folate, B12, these are not only required at cellular levels, but also at, subcellular and cellular functions. So that is important. Second thing is, again, for every patient of anemia who comes to me also, I go into depth of history because unless you find out the reason why this nutritional anemia is there, I mean, somebody who socioeconomically low status, there's that, you can understand, poor diet in the family. But otherwise, if otherwise a fairly better family, you must find out what the reason is for, this anemia. Other thing she brought out, Dr. Amrita, is the retic count. As I said before in the earlier talk also, retic count is the window to the bone marrow function. So every patient of anemia that you see, you do a CBC, you get your indices, but one retic count at some point should be there because you may miss some things, where you have a very low retic count or a high retic count, and some diagnosis, may get delayed because of not having adequate information. And so it is also important to know that we have this national anemia control programs. And in fact, the government has come up, I think in 2018 or 19, with guidelines for management of nutritional anemias. And it is worth going through them. And lastly, I just want to talk about one more thing, especially in respect to iron deficiency, that apart from, iron deficiency and anemias, we also in clinical practice see, even you must be seeing, refractory iron deficiency anemia. So in that, in my opinion, there are two types. One is, truly refractory iron deficiency, like a Thal minor or some other causes which are not actually iron deficiency, but present with low MCV, low hemoglobin, and you think they are iron deficiency. But other than that, there is this group of what I think is pseudo-refractory iron deficiency anemias, where your history taking is important. And 2-3 causes I want to mention here. One is pica. So pica is a symptom of iron deficiency, but it can also be a cause of iron deficiency. So, they get into this vicious cycle. Sometimes they have behavioral problems. And I've seen children eating all sorts of things, raw rice, raw onion, raw potatoes. I've seen a child, in this kurmura walas, they sell this limestone, which pregnant women apparently eat. So they buy that and they eat that, and all these things, they are rough and they cause, not only they bind the iron, but they also cause bleeding from the GI tract. So that is one cause which you will get only on history, and a very persistent history. They never tell you in the beginning. Second thing I've found is giving calcium supplements along with iron supplementation. So the calcium, bivalent ions compete with each other for absorption, and you can get an iron refractoriness if you're giving calcium along with iron. Third thing I've found is that children often are consuming, the ones with refractory anemia, huge amounts of milk. Means there are children, one and a quarter liter of milk they are drinking at the age of 1.5 years to up to 2 years also I've seen. And again, the same thing, the calcium competes with the iron. So these, pseudo-refractoriness, you can deal clinically and prevent a lot of harm to the child. Of course, folate B12, that's another topic altogether. But that's all. Thank you.
Thank you, ma'am. There are a few questions from the audience. Should we take it? Role of IV iron therapy in children.
Okay, so I'm glad somebody asked this, because practically speaking, even as a hematologist, I have very, very rarely used parenteral iron therapy. So it is a very rare child who has intolerance to iron or some kind of diarrheal disorder where you may need to resort to parenteral iron therapy. Most of the parenteral iron is more used by obstetricians rather than us. But today, if you have to use, then, iron sucrose is a good preparation, isomaltose, and those are also good preparations. And they're fairly safe compared to, the ones which we used to have earlier, and where we used to give intramuscular and all that. But practically, I can recall very handful of patients where I've used parenteral iron. I personally don't like to use unless I'm really pushed to it.
Okay, thank you, ma'am. Thank you so much. One more comment is there that B12 and folate tests are expensive and should be done along with homocysteine, which adds to the cost. So, what you want to say about this?
So one thing is that you can based on your MCV and other things, you can suspect megaloblastic anemia. Another thing that megaloblastic anemias usually have, which I use as a marker, is high LDH. So if you do their serum LDH, it is like 800, 900,000. So that can be an indicator of megaloblastic anemia. But just remember that low hemoglobin with leukemia also can have high LDH. But low hemoglobin, very high MCV, means 100 MCV, and high LDH can suggest folate B12 deficiency. So if you have nothing suggestive of leukemia or no high index of suspicion for that, you can safely treat these patients if investigations are expensive or not feasible. And homocysteine, we don't routinely do it unless you're talking about other diagnoses where folic acid is required. So otherwise, and one more thing I want to just, sorry, I'm going back to iron deficiency, wanted to add is that even sometimes, investigations for iron can have fallacies, like serum iron, TIBC, it depends on the lab that you're, who's doing it. Even ferritin, it's an acute phase reactant. So it can be actually normal or even elevated in children with iron deficiency anemia. So if you have this CBC with hemoglobin, low MCV is a very good indicator. But the best test, one of the best tests is a therapeutic trial with oral iron. Okay.
Thank you so much. There are a few more questions. Should we take the questions or move ahead?
You decide.
One last
we take it quickly. Just finish off quickly because it's an important topic. Maybe we could just finish off the questions quickly.
Yeah, and one more question is, what is the incidence of methylmalonic anemia seen in India, and how many patients you come across in your OPD?
These metabolic disorders are rare disorders. So, anybody in their clinical career may see a handful of patients. So it's something which, when you have refractoriness and other things, then you suspect it. But upfront, we don't suspect these conditions. But I mean, you have, again, all these you have to have a high index of suspicion, but they are not common. So I might have seen one or two maybe.
Thank you.
Years. Yeah.
Yes. And what is the role?
Diksha sir wants to comment. Sir, may you please unmute yourself?
Okay. So all of these questions I had put it just for the people to understand that, they don't have to do methionine, the B12 folate in every patient. Just treat them. If they don't respond, you always have a chance. Second thing, to me, doing just B12 folate without homocysteine has no meaning. You have to show functionality that those are affecting the hemopoiesis, then the homocysteine will be high. In fact, you should also do methionine because then it will pick up those rare metabolic disorders. And lastly, when you have a small child with megaloblastic anemia picture, or someone is having features of hyperhomocystinemia, think that it is a B12 metabolic disorders. So depending on where you work, if you are in a tertiary care hospital with a very good neurologist, we keep on seeing this in India because Dr. Udani is there. We see these babies with those congenital cobalamin deficiency disorders because of the metabolic pathways. And they are very fascinating to treat because you can treat them with hydroxycobalamin or methylcobalamin daily injections. So that's the point I wanted to make. And about IV iron therapy, there are definite roles. Like you have malabsorption syndrome, which is not correctable, or you have celiac till the time he's responded by a good GI epithelium recovery, or someone with chronic renal failure, or someone who is on chronic renal treatment with erythropoietin. These are all the indications. Lastly, if you are bleeding, which is out of proportion, like you have multiple polyposis, like a Peutz-Jeghers, there is no way you can match with oral iron. You have to give them IV iron. And today, even IV carboxy maltose is approved for children, and that's a single dose, complete dose. Like IV Scroxyme, you can't give more than 4 mg per kg. You have to divide over 3 or 4 or 5 weeks, depending upon how much is the volume required. But carboxy maltose, you can add one stroke, give in 1 hour, 2 hours, and that's it. So, and it's extremely safe. No anaphylaxis can happen. So that's the Those are the remarks that I wanted to make. Thank you.
Thank you so much,
Sir,
sir.
Madam, just a minute. Nitin sir,
Yes, sir.
again, I would give you the responsibility to give all the take-home messages at the
Oh no,
end.
sorry, I joined little late because I had a parallel meeting. So
It's
I
okay,
think let
whatever.
Rashmi,
No,
let
I
Rashmi
think
or
we should make him the expert rather than us. Yeah.
Dr.
No, no,
Kanwinde
He is
I
is
was
very
super
beginning to
into it.
expert.
Don't worry.
understand that this is the, about common things happen commonly. But you
I
can, I think, take the
yeah.
next case.
Yeah,
Dr. Nitin
just
Shah can take
last
over the
pressing
next.
remark, Rashmi, if you allow me, that for the I think there are more than 300 people, I'm sure from interiors of Maharashtra, that you don't treat iron deficient state and anemia in time, and if that fellow is moderately anemic as a child, then you treat them with iron, the anemia will correct, but the cognitive dysfunction will remain permanent. And I have many families where the mother continues to give bottle feed, milk feed, and she doesn't just give up. The child's hemoglobin is 5, 6, 7, 8. She doesn't listen. All I have to tell them is that your child could have become doctor, but because you are giving bottle, he may actually become a male nurse. And that hits them hard and they stop the bottle the next day. So you can use such drastic statements so that they just stop the bottle. One of the commonest reasons for iron deficiency in our country is too much of milk, whether it is breast milk beyond 18 months or whether it is top milk with bottle.
Right.
Thank
I think you can,
so
Dr. Nitin
endless
Shah can
topic.
take
So
over the next presentation. I think it will be good.
Shailesh is there, huh? I saw
Yeah.
Shailesh.
Shailesh sir is there, yes.
Shailesh, I can see him smiling. Please go ahead. I'm
Hi
looking
sir.
and
Hi sir.
There
कैसे
are
हैं?
there are 3 more
all
presentations.
well.
Yes, we start with the next presentation.
okay,
Yes.
yes, I will invite Dr. Bhim Singh Misal sir, who is consultant pediatrician at Janai Bal Rugnalay, Bid. Over to you, sir. You will be speaking about hemoglobinopathies and immune hemolytic anemia.
Bhim Singh sir, kindly unmute yourself.
Able to see the screen?
Yes,
ma'am.
ma'am.
Yeah, please start.
Topic is hemoglobinopathies and immune hemolytic anemia. The hemoglobin is a tetramer of 2 pairs of globin chains. If abnormality in this protein known as hemoglobinopathies, its abnormality could be quantitative or qualitative. Quantitative abnormality known as thalassemia and qualitative abnormality in hemoglobin production known as sickle cell anemia. Group of thalassemia. Thalassemia is known as a Cooley's anemia. It is a group of genetic disorder of globin chain production, and thalassemia is autosomal recessive inheritance. It's most commonly seen in Sindhis, Punjabis, Khatris, Gujarati, Mahar, Muslim, etc. Thalassemia depends upon the chain abnormality in the chain production. If the beta chain production is impaired, that is beta thalassemia, and alpha chain production is impaired, that is alpha thalassemia. Beta thalassemia is of 3 types. That is a beta thalassemia major, that in which 2 mutated genes and there is a moderate to severe signs and symptoms. In thalassemia intermedia, there are mutated 2 genes are there, but its manifestation is milder and not depends on the transfusion. In thalassemia minor, also called thalassemia trait, 1 mutated gene is there, hence the symptoms are mild. Main topic is beta thalassemia major. Beta thalassemia major is a severe form. It is a transfusion dependent anemia. It is present in homozygous condition. These babies, which are thalassemic major, are usually healthy at birth and develop signs and symptoms during second 6 months of the life and mostly within the first 2 years of life. The genotype is complete absence of the beta chains or partial synthesis is there, expressed as a transfusion dependent anemia. The clinical features of thalassemia major, patients are the pale or anemic or slight yellowish discoloration of the skin. There is a growth delay, failure to thrive, exercise intolerance, pathologic bony fractures, abdominal symptoms due to marked hepatosplenomegaly that causes stretching of the peritoneum and that will to the abdominal symptoms. Thalassemic facies, that is also called as Chimpmuk facies or hemolytic facies, due to abnormal extramedullary hematopoiesis that causes maxillary hyperplasia, flat nasal bridge, frontal foci, and abnormal dentition. This is a typical thalassaemic phases. Here there is abnormal dentition and all of them. The diagnosis of the thalassemia major, the basic CBC shows low hemoglobin count and RBC indices are very low. That is MCV, MCH, and MCS are all are low. Retic count is low, less than 8%. Unconjugated bilirubin may be elevated. Serum ferritin transferrin saturation level is also elevated, and it may be because of the increase in the gut absorption of iron or repeated chronic transfusion. Our antenatal diagnosis of the thalassemia can be done by chorionic villus sampling at 10 to 12 weeks of the gestational, or fetal blood sampling at 18 to 20 weeks of the gestation. The peripheral smear shows target cells and microcytic hypochromic cells, Howell joil bodies, and sometimes basophilic stippling in peripheral blood smear. The X-ray of the skull shows hair on end appearance or the crew cut appearance in the thalassaemic patient. The specific test, HB electrophoresis and high performance liquid chromatography. HB electrophoresis shows fetal hemoglobin of 98%, while A2 hemoglobin is 2%, while adult hemoglobin is less likely. This is rare. And if the DNA analysis can be done, if there is a transfusion is already in the patient, we can do DNA analysis for diagnosis of the thalassemia. The treatment part of the thalassemia is mainly the transfusion therapy. The goal of the transfusion therapy is to prevent the anemia and to suppress the endogenous erythropoiesis. Who to transfuse? Those patients with the thalassemia major with thalassemia intermediate hemoglobin less than 7 gram per deciliter, severe bony changes, significant hepatosplenomegaly, or progressive growth retardation. Blood of choice is leukocyte depleted packed cell transfusion is done to avoid the blood from the near relative. How much to transfuse? About 15 to 20 ml per kg packed cell volume with hematocrit more than 60% and not older than 2 weeks of the storage. That transfusion is done over 4 to 6 hours to maintain the pre-transfusion hemoglobin 9.5 to 10.5 gram per deciliter. The frequency of transfusion is a 3 to 4 weekly. An advantage is that transfusion prevent the chronic hypoxia, excessive ineffective erythropoiesis, bony deformities, and hypersplenism. Chelation therapy. Chelation therapy is to prevent, to decrease the serum iron level. Because of the repeated transfusion, 1 ml of the blood contains 1 milligram of the iron that causes the iron overload, and also the transfusion and as well as compensatory absorption of the iron from the gut that also causes iron overload. For that, we have to start the chelation therapy. Criteria for the initiation of the chelation therapies, it is after 1 year of the transfusion or serum ferritin level more than 1000 nanogram per ml that usually occurs after 10 to 12 transfusion, or liver iron is more than 5000 microgram per gram dry weight of the liver, or iron chelation is generally not labeled as used for in the children less than 2 years. Some iron chelators, some parenteral and oral. Desferoxamine is a parenteral iron chelators, while deferoxerox and deferriprone both are the oral. Deferoxamine is a good one, but it requires continued transfusion of the 10 to 12 hours in 5 to 7 days per week. But due to the continuous transfusion, there is a non-compliance and some adverse effect that like ototoxicity, retinal changes, bony dysplasia, truncal shortening is also the side effect of the desferoxamine. Deferoxerox and deferriprone, these are the oral iron chelators. Deferoxerox is the oral. T-half is more than 16 hours. That's why it is taken as an OD dose. Starting dose is a 20 mg per kg per day as a single dose. We can escalate 40 mg per kg once a day. The side effect of deferoxerox is the renal damage. For that, we are monitor the serum creatinine level or urinary protein. Deferriprone is known as Kelfer. It is oral chelator. That is T-half is a 3 hours to 4 hours. That's why we are taking thrice in a day. The initial dose is 75 milligram per kg per day. Divided in 3 doses, we can escalate into 99 milligram per kg per day. Most serious side effect of the deferriprone is transient agranulocytopenia. Hence, we need to CBC monitoring, and that is a deferriprone is a tiny particle that help into reducing the cardiac hemocytosis along with deferoxamine. iron overload monitoring is done by using serial serum ferritin levels and T2 star weighted MRI. Quantitative cardiac iron overload after 7 years of the transfusion and hepatic and pancreatic iron can be done. Endocrine functions can be monitored after 5 years at 5 years of the age or 3 years of the chronic transfusion. The splenectomy is done in the indication of the splenectomy is the large spleen with risk of the ruptures, abdominal pain or discomfort, falling steady state of hemoglobin or increase in blood transfusion requirement, presence of bipenia or bicytopenia or pancytopenia, evidence of hypersplenism on nuclear studies. These are the indication for the splenectomy. Prerequisites for the splenectomy. Before the splenectomy, we need to immunize 3 to 4 weeks prior to the splenectomy by pneumococcal, meningococcal, or H influenza type B or typhoid vaccination. That is a capsulated organism. Penicillin prophylaxis is also indicated to before the splenectomy, and parenteral counseling is also necessary. Hematopoietic stem cell transplant, that is bone marrow transplant, is the permanent cure for the thalassaemic patient. First time bone marrow transplant is done by E. Donald Thomas. First bone marrow transplant in India is done in CMC Vellore. There is, for the bone marrow transplant or hematopoietic stem cell transplant, HLA matching sibling is necessary. And if you are doing the bone marrow transplant before 14 years of age, or when iron storage are less or hepatomegaly is not there, then the success is high. Otherwise, if you are doing more than 14 years or excess of iron stores and hepatomegaly was there, the success rate of the stem cell transplant is poor. Recent therapy for the thalassaemic patient is the luspatercept. It is the parenteral drug which are used in FDA approved. It is used for more than 18 years of the age that enhance the erythroid maturation. The dose of the luspatercept is 1 milligram per kg subcutaneously once in a day, once in a thrice weekly. Mitapivat that increase the RBC specific pyruvate kinase and that improves the intracellular ATP and that improves survival of thalassaemic patient. These are the newer therapies. Complication in thalassaemic patient are because of non-transfused patient due to severe ineffective erythropoiesis that lead to severe anemia, growth failure, hypersplenism, abdominal symptoms because of the hepatosplenomegaly, thalassaemic phases, failure to thrive, or death. Death are because of the cardiac hemosynthesis. In transfused patient are complication are because of due to iron overload. After 1 year of the chronic transfusion, their liver hemosiderosis occurs. And in endocrine dysfunction, that is hypothyroidism, hypogonadotrophic gonadism, growth hormone deficiency, hypothyroidism, diabetes mellitus. After 8 years of the chronic transfusion, cardiac hemosiderosis may occur, and that means the most common cause of death in thalassaemic patient. Beta thalassemia intermedia, that is a similar stigma like the major, but usually present later age because partial production of the beta globin chain is there. That is expressed as non-transfusion dependent anemia, and hemoglobin is generally 6 to 10%, less severe than the major. Moderate anemia, microcytosis, and hypochromia may be seen. HB electrophoresis suggestive of the fetal hemoglobin is 70 to 75%. A2 hemoglobin is 2%, and trace of the adult hemoglobin. Thalassemia minor is also known as beta thalassemia trait, is diagnosed at later age. The peripheral smell shows microcytosis, target cell, minimal anemia. That similar picture of the beta thalassemia minor is the iron deficiency anemia, but differentiate between the thalassemia minor and anemia is the red cell distribution width. Red cell distribution width is increase in iron deficiency anemia, while the beta thalassemia minor, it is normal. Next step is a mass screening test. That is a naked eye, single tube, red cell osmotic fragility test. It is useful to differentiate other thalassemia from the thalassemia trait. That is a major intermediate trait. Lab investigation shows MCV is reduced, hematocrit is less, HB electrophoresis suggestive of adult hemoglobin is 3.5, A2 is 3.5 to 7.5, adult hemoglobin is 80 to 95%, and fetal hemoglobin is 1 to 5%.
Doctor, time is up. Huh?
Yes, ma'am. Can you move fast, please?
Yeah, fast.
Alpha thalassemia is depends upon the how much alleles genes are deleted. These are 4 types. If 1 allele is deleted, that is a silent carrier. If 2 alleles get deleted, is a trait, and 3 alleles get deleted, that is hemoglobin H disease, and 4 are get, that is hydrops fetalis. Hydrops fetalis is the expressed as the in utero death. While when 3 alleles get deleted, that is hemoglobin H, that is consist of the 4 beta chains. It is present as a moderate to severe anemia and require the transfusion or splenectomy. While when 2 get alleles get deleted, that is the mild anemia, that is similar to the iron deficiency anemia. In alpha thalassemia trait and iron deficiency anemia, we are differentiated by taking the good dietary history. In iron deficiency anemia, there is a deficiency intake of the iron intake is less, while and some pica is there, history of there. Or if you are giving the trial of the therapeutic iron in the iron deficiency anemia get corrected, while alpha thalassemia alpha thalassemia trait is not get corrected. It is a short alpha thalassemia. Sickle cell anemia. Sickle cell anemia is the qualitative abnormal production of the hemoglobin chain. It is an autosomal recessive disorder in which at the 6th position of the beta globin, that is glutamate is replaced by valine, that leads to sickle hemoglobin. That sickle hemoglobin causes calcium influx and potassium leakage at the post capillary venules, that is stiffness, fissures, and rigid cells occurs. The cycling and decycling, that post capillary venules, causes veno-occlusion, that causes microinfarction, ischemic pain, autoinfarct, that is autosplenectomy may get gallstone, leg ulcers, and due to the rigid cells, some RBC are disturbed and causes the anemia and jaundice. Clinical manifestation, hand-foot syndrome is the first manifestation of the pain, that is known as a dactylitis. Fever and bacteremia is a serious presentation in the sickle cell anemic patient. If fever is occur, we have to admit the patient and diagnose the properly for the fever and need the IV antibiotic. Vaso-occlusive crisis, aplastic crisis, when the patient is a sickle cell anemic and comes with severe anemia with retic count is 0, we suspect the aplastic crisis and associated with the PAROB-19 infection. Splenic sequestration crisis is most occurs in age between the 6 months to the 2 years. In splenic sequestration crisis, the sudden drop of the hemoglobin occurs. That is a 2 gram per deciliter of the hemoglobin is a decline from the baseline. For splenic sequestration crisis, we have to transfuse cautiously. Otherwise, after the episode of the sequestration crisis resolve, that will causes hyperperfusion and hyperviscosity. Acute chest syndrome that is presented by fever, pain, dyspnea, pleural effusion. Pleural effusion is most commonly occurs in left lower lobe. Avascular necrosis is most commonly seen in femoral head. Priapism is also seen in unwanted painful erection of the penis, and commonly seen in early morning and at age of the 15 years. Sometimes there is a neurological manifestation also occurs in the form of the posterior reversible encephalopathy syndrome. The diagnosis of sickle cell anemia is done by hemoglobin and ESR at the low, while raised retic count and unconjugated bilirubin. HB electrophoresis shows sickle hemoglobin is more than 80%, fetal hemoglobin is 1 to 20%, and A2 hemoglobin is 2 to 4%. Peripheral blood smear shows sickle cells, increased polychromasia, nucleated red cell, and target cell. Sickling test is the positive in the sickle cell anemia by using sodium metabisulfate.
Sir, your time is getting up.
Yes, ma'am, yes. Management is parental education about disease complication and all that required. Hydroxyurea is the main therapy of the. We need parental education, maintain hydration, avoid extreme cold and heat exposure, heavy exercise that will cause sickling of the cells. Diet rich with omega-3 fatty acid, vitamin A, zinc we have to give. Immunization, that is pneumococcal, meningococcal we have to give. Oral penicillin prophylaxis should be offered in all sickle cell disease. Yes, ma'am. Pharmacological measures, that is hydroxyurea, that is a myelosuppressive agent that is used started in infants 9 months of age and older children with sickle cell anemia regardless of the clinical severity. Starting dose is a 15 to 20 mg per kg per day. Once in a day, we can escalate 35 milligram per kg per day. 5 milligram per kg per day, per 4 weekly you can escalate. That reduces the hydroxyurea is the painful crisis, all the sequestration crisis, hospitalization, prolong the survival, and with hydroxyurea can be stopped when the neutropenia and thrombocytopenia occur. Also, L-glutamine is also used as a pharmacological therapy, and folic acid is also started. blood transfusion, iron chelation, hematopoietic stem cell transplant is the only curative for the sickle cell anemia. Recent therapy is crenalizumab is against the P-selectin that prevent the vaso-occlusive crisis. Oxalator is a sickle hemoglobin polymerization inhibitor. Autoimmune hemolytic anemia, that is a immune hemolytic anemia. It is a hallmark of these positive direct antiglobulin test. That is two types, warm autoantibodies and cold antibodies. Warm autoantibodies immune hemolytic anemia is the most common, that is IgG mediated, and it is two types. Primary is the most common, that is idiopathic, and secondary is because of lymphoproliferative disorder, connective tissue disorder, SLE or rheumatoid arthritis. Cold autoantibodies type immune hemolytic anemia is cold agglutinin disease or paroxysmal cold hemoglobinuria. Cold agglutinin disease is IgM against the I antigen of the RBC. It is the most common seen in the paroxysmal cold hemoglobinuria is against the antibody against the P antigen of the RBC, and it is also known as the Donald-Lancet hemolysin antibody mediated. Clinical feature, that is acute transient type, is the most common, 70 to 80%, lasting for 3 to 6 months. Most commonly seen
Doctor, do it fast. We already 25 minutes,
12
please.
years of pressured by infection. That is the most presented as palar jaundice, fever, hemoglobinuria, splenomegaly. Recovery is full, low mortality rate, and good response to steroid. Chronic one is occur in infants and children more than 12 years. Hemolysis continue months to year. Lab diagnosis is the reticulocytosis, spherocytosis, polychromacy, and direct test is positive. Treatment is blood transfusion and steroid, that is prednisolone, 2 to 6 milligram per kg per day. That continues steroids till the direct test get negative. And for severe cases, we can give IV, IG, rituximab, or plasmapheresis. Thank you.
Thank you so much, Dr. Misa. I would like to request Dr. Shailesh Kanvinde sir, kindly give your expert opinion on this. Dr. Shailesh sir.
Nitin sir, please.
Nitin sir can give the comment.
अरे किधर गया शैलेश, फोन करो
हाँ
उसको।
सर हूँ, लेकिन थोड़ा कुछ लोडिंग का प्रॉब्लम हो रहा था।
हाँ ठीक है, ठीक है,
अदरवाइज
गो
ठीक है।
अहेड।
नहीं, I'll just सर हाँ ओके।
नहीं, आप करो, अरे आपका प्रेरोगेटिव है।
अरे सर जी
Okay,
anyway,
I'm eager to hear. I'm eager to hear you.
At the outset, let me thank MahaIP for inviting me here, and I've been listening to all the presentations so far. They have been pretty good. So regarding thalassemia, I think much of it has already been covered by the speaker. There are certain things that I would just like to add. I understand that there are a lot of people here who are practicing in the periphery. Generally, thalassemia, when we say, it's like a multidisciplinary management, and we do require inputs from various specialities. But when you're practicing in the periphery, I think you need to focus on two aspects. One is adequate transfusion and adequate chelation. And these are two of the most things. Most often we realize that transfusions are very often given, but chelation is generally inadequate, and that leads to a lot of complications which cannot be corrected later on. How do you decide about adequate transfusion? One, obviously, is the monitoring the hemoglobin pre-transfusion, as the speaker has mentioned, between 9 to 10. Other things clinically you could also look at is those children who are inadequately transfused tend to develop the thal phases. So if a patient is having prominent thalassemia phases, one could safely assume that the transfusions requirement of that child is not being properly provided. The second thing that happens is that they develop increasing splenomegaly. If this is not tackled early in the early ages, this splenomegaly tends to increase and later on land up with hypersplenism and needing a splenectomy later. So we should be avoiding splenectomy in our children, especially thalassemics, because not only is the risk of post-splenectomy sepsis there, but also they can have other complications like pulmonary hypertension later in adult life. So our objective would be to see that these spleens are well controlled early in life, and that is possible with good adequate transfusion. The second part is adequate chelation. Serum ferritin is a useful marker. It has its limitations, but I think that can be carefully monitored, and adequate chelation starting at the day, time points which Dr. Bhim Singh mentioned should be done for all children. It's now easier to give iron chelation. We no longer need to give the injectable form. Good oral formulations are available. So I think these are the two things which one needs to really focus on in managing children with thalassemia. Right.
Thank you. Yes, thank you so much, sir. We will take audience questions maybe later on if time permits. We will move ahead with next topic. I'll invite Dr. Mohini Apte. She is Associate Professor at IGGMC Nagpur. She's been trainer for basic and advanced NRP and more than 10 international and national publication on her name. Her area of interests are neonatology, sickle cell disease, breastfeeding promotion, and counseling. And her topic is anemia of systemic disorder. Over to you, ma'am.
Thank you, Dr. Sapnani. I thank MahaIP and the Women's Forum for giving me this opportunity today to talk on anemia of chronic diseases. Now, anemia
Doctor, you have 10 minutes.
Dr. Mohini, can we be a little louder?
Louder.
Yeah. So, anemia of chronic diseases was first described by Cartwright almost half a century before. It is basically an anemia which is described as mild to moderate anemia, normocytic, normochromic, and a hypoproliferative anemia. So it's also known as anemia of inflammation, anemia of chronic inflammation, hypoperemia of inflammation. So hallmark is a combination of low circulating iron levels, low transferrin saturation, and normal or high concentration of iron storage protein that is affected. It was initially thought to be associated primarily with infectious, inflammatory, or neoplastic diseases. But over a period of time, people have found that it can be associated with obesity, diabetic mellitus, congestive heart failure, critical illnesses, severe trauma, and other forms of disease where there can be acute or chronic immune activation. Now, the pathogenesis is multi-pronged, but basically related to inflammation. It is thought to be an evolutionary defense strategy of the body to limit the availability of iron from invading microbes, thereby reducing the proliferation of these organisms. So it is basically aimed at reducing the iron availability. This is basically mediated via the immune dysregulation of iron hemostasis, and two important parameters which play a role is hepcidin, which is the master regulator of iron homeostasis, and the cytokines. So the cytokines basically work at multiple levels. The cytokines stimulate the macrophages to ingest a lot of RBCs and then retain it inside. It does not allow the RBC which is formed inside the destroyed inside the macrophages, and the released iron is not released outside. So basically, cytokines affect the iron uptake and cause retention inside the macrophages. It also, cytokines, both in interleukin-1, interferon gamma, and TNF, also reduce the erythropoietin secretion and its effect. About hepcidin. Now, hepcidin is the master regulator of iron homeostasis. Now, what it does is, it works or it binds to the plasma membrane channel protein called ferroportin. So basically, it's a channel. Now, hepcidin binds to this ferroportin and leads to internalization and degradation of this protein. That is, the channel is blocked, and this prevents iron from getting absorbed at the level of intestine, or it's released from the macrophages into the circulation, thereby reducing the serum. Another method is by reduction of RBC production. The inflammatory mediator directly inhibit the erythroid cell differentiation and proliferation in the bone marrow, and also induce apoptosis via the ceramide or the radical mediated pathways in the marrow and cause destruction of the erythroid cell precursors. It also, the inflammatory cytokine also reduce the RBC survival, that is the RBC lifespan is reduced. This is mediated through free radical formation, which damage the membrane lipid peroxides, and therefore, and also it increases the receptor which on the macrophage, which causes scavenging of damaged RBCs. So more and more RBCs are taken inside macrophages, they are destroyed, but the iron is not released into the circulation. So since it is an anemia of chronic disease, there have to be a lot of underlying conditions which will present in this condition. So it will be a concomitant condition to a lot of other underlying diseases. Most foremost important is the autoimmune or the autoinflammatory disease, out of which inflammatory bowel disease, especially in children, is very, very important, like Crohn's disease, collagen vascular diseases, especially the juvenile idiopathic arthritis or SID. These are all chronic conditions where cytokines are running amok. Then there can be vasculitis situations like polyarthritis nodosa or vaginal granulomatosis, sarcoidosis or Castleman disease. Chronic kidney disease, I've already added another slide, so we'll go to that. Hematologic malignancies like lymphoma and leukemia can also have an anemia of chronic disease along with the anemia of reduced production. Various chronic infections, in fact, can present with anemia of chronic disease, importantly chronic urinary tract infections, various skin infections like streptococcal fasciitis, endocarditis, osteomyelitis, pneumonia, septicemia, tuberculosis, and many other systemic bacterial, parasitic, viral, fungal infections which are chronic. Critical illnesses or trauma in the acute phase will present as acute severe anemia, but later on they can present as acute anemia of chronic inflammation or chronic disease. Obesity, which is a new pandemic coming up for children, can also present as anemia of chronic disease. A word on kidney disease. In kidney disease, in chronic kidney disease, in acute phase, in initial phase, there is obviously decreased production of erythropoietin, which leads to anemia. But in advanced chronic kidney disease, when children are on dialysis, there is a generalized increase in the inflammatory response. Also, there is reduced during the excretion of the hepcidin, which we have already discussed, the key regulator of iron metabolism. And this further contributes to macrophage iron retention, and therefore iron deficient chronic anemia of chronic disease, and decreased erythropoietin stand there concomitantly to produce anemia.
Mohini madam, 2 more minutes. You're almost done. Almost done.
Making the diagnosis is there's no single test to make the reliable diagnosis, but it is a pattern of abnormalities and exclusion of other possible diagnoses which help to make the diagnosis. Major challenges to distinguish between anemia of chronic disease from iron deficiency in individuals with inflammatory conditions, because there are situations where the child is losing blood because of this diarrhea, bloody diarrhea, or there are other contributing factors to disease like in hematological. So CBC, it is a mild to moderate anemia, so hemoglobin will not be very, very low. But it is the hallmark is a normal MCV and normal MCHC. Reticulocyte count will be low. So, and the blood smear will show uniform cells. So, RDW is also normal, because RDW is also normal. So, the smear will show uniformity or in RBC cells. CRP and ESR will be high because there is an underlying inflammatory condition. Bone marrow will show increased iron in the macrophages, while erythroid precursors will be less. So basically, it is a normocytic non-chronic anemia with hypocellular. Another test is the soluble transferrin receptor protein, which is a cleavage protein of the transferrin receptor. When there is iron deficiency anemia, the aim of investigation is to differentiate between iron deficiency anemia and anemia of chronic disease. So all these newer tests help in deciding whether it is in the iron deficiency anemia or it is anemia of chronic disease. So this cleavage protein will increase if there is underlying iron deficiency, because in iron deficiency there will be increased number of transferrin receptors. So, and there is this ratio called serum transferrin receptor protein with ferritin index. The ferritin will be low in iron deficiency anemia, while it will be normal to high in anemia of chronic disease. So this ratio will help us to make a diagnosis. Iron studies will also help. The serum iron concentration in anemia of chronic disease is low. Transferrin is low. Transferrin saturation is low, but ferritin is normal to increase. Another test which can help in differentiating anemia of chronic disease from iron deficiency anemia is the reticulocyte hemoglobin content. So this reticulocyte hemoglobin content is indicator of iron deficiency. If the reticulocytes have no iron, the diagnosis will fall into the category of iron deficiency. So anemia of chronic disease will have either concomitant iron deficiency, or you have to differentiate it from iron deficiency. The features which will suggest iron deficiency, concomitant iron deficiency, are microcytosis of peripheral square, and ferritin, if it is low, will indicate iron deficiency and not anemia of chronic disease. This is a comparative chart. So basically, iron studies the reticulocyte hemoglobin equivalent, serum hepcidin, if it is available, serum erythropoietin, will help in making or differentiating iron deficiency anemia from anemia of chronic disease. So, for management, the goal of actually the symptoms are usually related to the underlying condition and not because of anemia of chronic disease. So the goal of treatment is to reduce symptoms and improve clinical outcomes and not to normalize it. Treatment of underlying disorders is the primary thing. Then there are specific things for management of ACD, and they are erythropoiesis stimulating agent like the recombinant erythropoietin or carbopoietin, which will increase the erythropoietin, or it will work like erythropoietin or increase the erythropoietin. And there are emerging therapies like hepcidin and antagonist. Now, hepcidin is causing the problem, so we have agents which help increase the hepcidin activity, or they work like the channel protein, the ferritin. So these are emerging therapies or the newer methods. I hope, Dr. I have been able to take inputs given by Dr. Kanwinde. I have tried to incorporate.
Nice.
Yes, thank you. Thank you, Dr. Mohini ma'am. Really wonderful presentation. I will request Dr. Shailesh Kanwinde sir to opine on this.
Okay. Yeah, thank you, Dr. Apte. That was a very good presentation and a brief summary of the topic. I would just like to add a few things. As you've highlighted that the mechanisms involved in anemia associated with any inflammation include iron restriction or iron restricted erythropoiesis, a direct suppression of the erythropoiesis, as well as reduced red cell survival. Now, this when we say anemia of systemic disease, it need not necessarily be a chronic disease. You can have anemia associated with acute infections also, which can present with a similar pathophysiology. There, mostly the cause for the anemia would be a shortened red cell survival, because the other two mechanisms would take some time for the hemoglobin to drop. But it is not unusual to see a drop in hemoglobin of 1 to 2 grams even in children with acute viral infections. So one need not be alarmed and to see a drop in hemoglobin, especially with acute viral infections. One could just wait and then proceed with follow up and then investigate later if the hemoglobin does not rise. The other point I wanted to mention was that anemia may, in some situations, point towards an underlying systemic disease. A simple example is iron deficiency anemia. I think it has been discussed in the previous speakers, but I just like to highlight one point here, is that iron deficiency anemia occurring outside the high growth spurts, the first 3 years and the pubertal age group, is extremely unlikely because of dietary factors. And in this situation, one needs to look at blood loss. And one of the common undiagnosed factors for this is celiac disease. So celiac disease can just present as iron deficiency anemia. So an anemia pointing towards a more systemic illness. Similarly, autoimmune hemolytic anemias can sometimes point towards a wider pathophysiology like SLE and so on. So these are just some of the comments that I would like to add on this. So if there are any questions, I'll be glad to take it.
Thank you, sir. You really gave practical approach. Questions we may not be able to take since it's too late.
Nitin sir wants to speak at this point. Nitin sir, please.
Yeah, just one point that, when you have anemia, chronic inflammation, like in a patient with systemic vascular disease like SLE or RA, which are going on and on, hemoglobin can really drop to 7, 8, and you want to avoid transfusion. The one way you can temporarily increase the hemoglobin is by giving IV iron. When you give IV iron, it bypasses the storage and the saturation that is happening at the hemosiderin level because of the high hepcidin, and some iron will actually get driven to the bone marrow for the erythropoiesis. So in malignancy patient or in patient with severe inflammation like SLE, etc., you can try. That's another indication of giving IV iron.
Thank you, sir. Moving towards our last speaker, Dr. Rupali Patil. She has done her DNB pediatric from Jahangir Hospital, Pune, and fellowship in neonatology from MUHS Nasik. And she has been co-guide for DNB students and MUHS pediatric intensive care fellowship students also. And presently she is working at Sai Sparsh Children Hospital, Kolhapur. She'll be speaking about anemia of bone marrow disorder. Over to you, Dr. Rupali. Yes.
Yes.
Yeah.
Dr. Rupali,
you are muted.
You are muted.
Unmute yourself.
Keep your video on, ma'am.
Unmute. Sorry.
Yes.
Thank you, ma'am, for the introduction. Good evening, all. Till now, we have discussed all the common types of anemia. And now we will head to the mostly rare, untouched, and little difficult and vast topic, anemia of bone marrow disorder. But I will try to simplify it. So anemia of bone marrow disorder, it can be a defect in the single lineage, means one cell line is defective, that is erythrocytes are defective, that is pure red cell aplasia, it can be inherited or acquired, or all cell lines are hampered, that is multilineage bone marrow disorder. It also can be inherited or acquired, it is aplastic anemia. So we will mainly focus on the pure red cell aplasia, and we'll briefly see aplastic anemia also. So pure red cell aplasia is anemia secondary to failure of erythropoiesis. On peripheral smear, we will see normocytic normochromic anemia associated with reticulocytopenia. Till now, we have seen all the anemias with reticulocytosis. Bone marrow will show absent or infrequent erythroblast. Platelets and leukocytes will be normal in number also and morphology also. This pure red cell aplasia was described first by Joseph in 1936 and subsequently by Diamond and Blackfein in 1938. So it is diamond and blackfan anemia. So this is congenital pure red cell aplasia is diamond and blackfan, or it can be transient erythroblastocytopenia of childhood, or it can be secondarily acquired. Acquired can be primary or secondary. Primary is mainly autoimmune origin or myelodysplastic anemia, and secondary acquired is mainly erythropoietin associated or ABO incompatible stem cell transplant associated, or it can be associated with lymphoproliferative disorders or associated with persistent parvovirus B19 infection, and many drugs that can cause pure red cell aplasia. So mainly in day-to-day practice, which can lead to pure red cell aplasia that we will see are isoniazid, procanamide, sulfonamides, penicillamine, azathioprine. These are the common drugs. Also, some recombinant erythropoietin. It is very rare, but it has shown causing pure antibodies and causing pure red cell aplasia. So we will see it in tabulation form. It can be congenital. It is diamond blackfan. Acquired can be primary or secondary. Primary can be immune myodysplastic, and secondary, as we have discussed. And then on history, as this is chronic anemia, the symptoms are mainly less because these kids are adapted to the anemia. But the general symptoms like generalized fatigue, decreased exercise tolerance, palpitations, in extreme cases when cardiac involvement is there, there can be pre-syncope or syncope. On examination, there will be pallor. In parvovirus B19 infection, there will be erythema, enthusiasm, a rash will be there. In immune disorders, there will be reticular lacy body rash. Lymphadenopathy, hepatomegaly, splenomegaly will be seen in lymphoproliferative disorders, that is acquired anemia. Congenital diamond blackfan and transient this erythropoietic anemia will not have organomegaly commonly. We will see diamond blackfan syndrome. The presentation is up to 2 months to 1 year, that is infancy. Thumb abnormalities are there, craniofacial dysmorphism is there, short stature, urogenital abnormalities, wave neck, and skeletal cardiac defects. So these are the special clinical features for diamond blackfan. So evaluation. So when we will try to evaluate, first we will diagnose anemia with complete blood cell count, differential and retic count. Retic count will be low. EPO level will be high. Erythropoietin level will be high. Then for secondary acquired anemia, we will search for the cause, that is anti-nuclear antibodies or anti-neutrophilic cytoplasmic antibodies, rheumatoid antibodies. The viral studies we will do like parvovirus B19, viral hepatitis A, B, C, E, HIV, EBV, CMV. And we will do flow cytometry of peripheral blood cells to rule out the malignant cells, malignant clonal cells. Of course, we will do bone marrow for the diagnosis, and it will show near absent erythrocytes, and the other cell lines will be normal. We will do cytogenetics, flow cytometry, and T cell gene arrangement, mainly for the lymphoproliferative disorder. Diamond blackfan syndrome for diagnosis of DBS is the special test available, that is erythrocyte ADA level. But this test means erythrocyte adenosine deaminase level will be elevated. Thus, this test, there are many challenges to do this test because this test is available in very few labs all over the world. Second thing is the test should be performed in patients who have not received blood transfusion previously. Third thing is it should be performed on the fresh blood sample or the blood sample stored at 4 degrees Celsius for few days only. It remains for 48 hours to 72 hours only. So these are the challenges facing for to do, but it is available. Then, of course, we will do the test to determine our iron overload because these patients undergo multiple blood transfusions. One thing one should remember that after we diagnose PRCA, pure red cell aplasia, one has to do PCR for parvovirus B19 because we have to rule out transient erythroblastopenia of childhood, and this has to be done because it has good prognosis. Then management of diamond blackfan we will see first. The mainstay of management is glucocorticoids. They respond very well. DBS patients respond very well to glucocorticoids. The dose is 2 mg per kg in 2 to 3 divided doses. The response occurs in few weeks. And then we have to give the maintenance regimen, 0.5 to 1 mg per kg or alternate day in a week, and then slowly taper off. If in 4 weeks the response doesn't occur, it means they are steroid non-responsive. Then we have to go for RBC transfusions. We have to keep the target of 7 to 9, and we have to take care of ion chelation also, take care of the ion overload. Then we can try the second attempt of steroid therapy after 12 to 18 months again. Then if all these fail, means steroid response is not there and the child becomes transfusion dependent, then one should go for stem cell transplant. The survival rate is very good, more than 90%. If the younger patients are given the matched allogenic stem cell transplant, the survival rate is very good. Other modality of treatment is also available for non-responders, like interleukin-3 high-dose methylpred and cyclosin. Then acquired PRCA. For acquired PRCA, mainly the treatment is pertinent to the cause. If the immune-mediated is the pathogenesis, cyclosporin is the first choice. Response rate is 75%, and it can be used alone or with prednisolone. Dose of cyclosporin is 6 mg per kg per day. Then corticosteroids were used before discovery of cyclosporin. Other cytotoxic agents are used for immunosuppressions are cyclophosphamide, tacrolimus, and methotrexate. Then these are other.
2 minutes more, please.
Yes. Then antithymocyte, globulin, rituximab, tacrolimus. These are IVIG, plasma exchange, and allogenic stem cell transplant. These are other modalities. Management. Then this is thymoma associated, PRC associated. These are according to the causes. Then transient PRCA, this we will discuss because it is associated with parvovirus B19. It resolves on its own with development of humoral immunity. And once the patient gets this, lifelong immunity is there. But if there is persistent parvovirus infection, means persistent anemia is there, then course of IVIG helps. We will summarize, means we will see the prognosis mainly. In congenital, they have normal lifespan with steroid responses, or with non-steroid responses also they can live for, with 30 to 40 years. Acquired have significantly shorter. Transient has good response. Aplastic anemia is mainly pancytopenia and hypocellular bone marrow. And etiology is mainly drugs related and infection related. Infections are seronegative hepatitis, CMV, EBV, and herpes or varicella, measles, adeno. These are the common causes of aplastic anemia. Nutritional drugs. One should remember chloramphenicol causes aplastic anemia, and certain chemicals, and immune-mediated. These are the major causes. Major inherited bone marrow disorders are Fanconi's, dyskeratosis congenita, diamond blackfan, again means single cell line, Schwammen diamond, severe congenital neutropenia, and congenital dyserythropoietic anemia. Then we will not go into this theory. We will see what we should investigate for diagnosis of aplastic anemia. One should confirm the diagnosis, exclude other possible causes of pancytopenia with hypocellular bone marrow, exclude inherited aplastic anemia, and screen for the underlying cause. So this will be one, when we know what we should do, we know the list of investigations. CBC, PS, HbF is elevated, bone marrow we will do, viral studies we will do, and flow cytometry. Urine hemosiderin is needed because they develop PNH. PNH is also is cause of aplastic anemia. So definitive therapy is bone marrow transplantation or immunomodulation therapy. Supportive therapy is transfusional support, hematopoietic growth factors, and prevention of infection and ion chelation. So we will come to the last slide. When we will suspect bone marrow failure as a cause of anemia. So when we will have reticulocytopenia, when we have normocytic normochromic anemia, in bone marrow, we have either absence or near absence of erythroblast, which will lead to, point to pure red cell aplasia, or hypocellular bone marrow, which will point to aplastic anemia. few symptoms of anemia. As the children, these kids are adapted, so there will be few symptoms, and sometimes family history will be there. So this is the summarization. Thank you. Thank you.
Thank you so much, Dr. Rupali. It was really a brief and brief presentation. So I would request Dr. Kanvinde sir, please give your expert comment on this.
Yeah, thank you, Dr. Rupali. That was a nice presentation and a brief overview of the topic. Where should I? So, just starting off with the last slide, where would you suspect, or in which patients would you suspect that the patient would have a anemia due to a marrow failure kind of situation? As you've had rightly, clinically, the child would not have splenomegaly because splenomegaly would point against the diagnosis. Then generally they will not have lymphadenopathy. They may have congenital anomalies or some dysmorphic features. And on peripheral smear, I mean, and with they'll have a low retic count. So these are the situations where one would consider the possibility of a marrow failure as the cause of the anemia, and in which case a bone marrow is almost invariably required. Bone marrow will tell you what the underlying cause is. It will rule out the other differentials such as megaloblastic anemia or malignancies, which could also present initially with such a picture. And it will also let you know what the other cell lines are. So to distinguish between a single lineage versus a multi-lineage pathology. Regarding diamond Blackburn anemia, just one or two points I would like to mention. Steroids generally are avoided in the first year because they tend to interfere with the growth and development, especially neurological development. So it is recommended that these children receive transfusions till 1 year of age, and then they should receive the steroids. Prognosis is generally good. A substantial number of these children would respond to steroids, and many of them can be weaned off steroids and can lead normal lives. There is a small risk of developing a malignancy in these patients because it's a marrow failure. So that has to be kept in mind. Regarding acquired red cell aplasia, I think one also needs to, if initial response to immunosuppression is not good, one needs to look at whether this is a late presenting inherited marrow failure syndrome. And so looking at doing an NGS to look at the other possible causes of inherited marrow failure could be a possibility. Yeah, I think that's all I would like to add.
Okay.
Nitin sir, please.
So just to add to what Dr. Shailesh has said, that number one, Fanconi's anemia can be completely phenotypically normal. So all aplastic anemias, you should work out for Fanconi's because the treatment is completely different. Second thing is, when you do a marrow, especially I see a lot of pediatricians doing marrow, they do only aspiration, they don't do biopsy. Aplastic anemia diagnosis is always on a biopsy. Number three is always do an HbF level because that will be high in Fanconi's anemia, which will again give you flu in an otherwise normal phenotypic child. And fourth thing is, we now always do an NGS in every aplastic anemia because we have seen some rare syndromes which are treatable without transplant. And lastly, acquired aplastic anemia, today the fulcrum has changed from transplant to using L-Trombopac plus cyclosporine as the drug of choice, and 8 out of 10 would actually respond for a long time. So, people are moving away from transplant to more of a pharmacotherapy. We have a series of 12 patients from Wadia and 6 from my own consulting. And out of the 18, except one, all 11 have responded to L-Trombopac and cyclosporine.
So thank you, sir, for the important messages. we have done the topic very well. We have summed up it very well. I would like to thank our experts for today, Dr. Rashmi Darvi Madam, Dr. Shailesh Sir, and Dr. Nitin Shah Sir for his special comments, important messages. Also, I would like to thank Dr. Ram Gopal Shijada Sir, Dr. Amol Pawar Sir, Dr. Manjusha Sherkar Madam, Dr. Gravita Raikar, co-chair of this committee, Dr. Bhavesh Mitra Sir, convener MahaAP, our speakers, Dr. Vaibhavi, Dr. Amrita, Dr. Bhim Singh, Dr. Rupali, and Dr. Mohini. Also, it was a wonderful experience having a co-host, Dr. Swapnali Madam. Also, the zonal members and EVs who had joined in between, Dr. Renu Madam and Dr. Kashmir and Dr. Amrita Madam, and the rest of the zonal and EVs who had joined. And also, a special thanks to our digital support by Dr. Pallavi Madam and Dr. Vishal for the digital IAP. Thank you all for the wonderful, and also the attendees who have taken special interest in the topic. Yes, Ram Gopal sir, kindly unmute.
From tomorrow, we are starting one more new series, that is Learning from the Legends. So all are welcome to join tomorrow at 9 o'clock.
Thank you, sir.
Thanks, Dr. Amruta and Dr. Swapnali for excellent moderation, and thanks, Dr. Grivita, for all logistics and support. Thank you so much.
Thank you.
Thank you, Shailesh sir, Nitin Shah sir.